Now, vignette number 9. As a 48-year-old woman with severe migratory necrolytic dermatitis for several years, unresponsive to all kinds of herbs and ointments. She's thin, has mild stomatitis and mild diabetes mellitus. This is the last of the endocrine abnormalities due to what the islands of Langerhans can do. In fact, historically, the insulinomas were recognized and described way back in 1927. The Zollinger-Ellison syndrome was described in 1955. But it wasn't until recently that we finally elucidated the existence of the glucagonoma. We knew intuitively there had to be there. There had to be a disease out there where the islands of Langerhans made too much glucagon. But we kept looking for those patients in the wrong place. We assumed those patients would be in the diabetic clinics as individuals with very brittle and very difficult to manage diabetes, but that's not what they were. These patients are all hiding in the dermatologist's office, because even though glucagonoma indeed gives a patient mild diabetes mellitus along with a little bit of stomatitis and glossitis, what they really suffer from is this terrible necrolytic migratory dermatitis that doesn't respond to management. Now, if you're having a question in the USMLE, necrolytic migratory severe dermatitis doesn't respond to management, the lady has stomatitis and a little bit of diabetes mellitus, you have to realize that the USMLE, if it gives you a dermatological condition, it's not likely to be diaper rash. It's going to be something really important, and this combination suggests the glucagonoma. So we begin by measuring glucagon. That's what's going to be elevated. And then the CT scan of the pancreas, which hopefully will find the tumor, and then the resection of the tumor. And the patient will have a very dramatic recovery. The subheading that we're now going into is surgical hypertension. As you know, there are millions of patients in the United States who have hypertension, and the vast majority of them simply have hypertension. Namely, it is essential hypertension. We don't know why they have it. But hiding among that large group, there's a handful of patients that have a surgically correctable reason for the hypertension. One that, if diagnosed and properly treated, will eliminate the hypertension. I'm going to review 4 of those conditions with you, and each of them, as we shall see, has something that allows us an easy early identification as soon as we read the vignette. Vignette number 1. A 45-year-old woman comes into your office for a regular checkup. On repeated determinations, you confirm the fact that she is hypertensive. When she was in your office 3 years ago, her blood pressure was normal. Laboratory studies at this time show a serum sodium of 144 milliequivalents per liter, a serum bicarbonate of 28 milliequivalents per liter, and a serum potassium concentration of 2.1 milliequivalents per liter. The woman is taking no medications of any kind. This one is hyperaldosteronism. Hyperaldosteronism affects primarily women. This is the right age group. And the lady that has the hyperaldosteronism has all the manifestations of excessive production of that hormone, beginning with the hypertension, which is what brings her to our attention here. But also she has a touch of hypernatremia, a touch of metabolic alkalosis, and she has low serum potassium. And low serum potassium is the red flag. Low serum potassium is what should alert you, given a vignette of a hypertensive patient, that you may be dealing with hyperaldosteronism. But there is a little proviso that has to be included. If you actually were to go to a hospital in the U.S. and look at all the individuals who are hypertensive and have a low serum potassium, most of them would be regular garden variety hypertensives who are on diuretics. and because they are on diuretics, they have a low potassium. So for this low potassium to truly be the red flag that says hyperaldosteronism, it must be specified in the vignette that the patient is not on diuretics, or perhaps in a more comprehensive way, that she is not taking any medications of any kind, as we just read. Now let me digress here for a second, because this observation that I just made has application for other exam questions. When one writes a vignette for the USMLE exam, the person writing the vignette has to have in a relatively brief text all of the pertinent findings that describe that condition. Therefore, in that brief vignette, there really isn't much room to be putting irrelevant negative findings. Now, some negative things are so common that they're meaningless. When we read in a vignette that the patient is afebrile, well, you know, let's not make a big thing out of a fact that he's afebrile. We put that in the context of the rest of the vignette. But when you read in a vignette, the lady is not taking any medications, is not on diuretics. I could think of a million other things this lady doesn't have. She doesn't have leprosy, she doesn't have a broken bone, she doesn't have a brain tumor. I mean, the list of negatives could be enormous. And so the point that I'm making is that a negative bit of information in a USMLE question is typically a very meaningful bit of information. There had to be a reason why you are being told this isn't happening. The patient doesn't have this diarrhea. Well, in this case, it is indeed what validates that the low serum potassium is due to the disease. So what are we going to do? Well, first of all, we're going to measure aldosterone. That's the hormone we think is being produced excessively, but that alone doesn't suffice, because you and I are constantly making aldosterone at different levels depending on our needs of the moment. But the way you and I physiologically have the aldosterone secretion is by way of a renin-angiotensin mechanism. So we measure both aldosterone and renin. If she were to have high aldosterone with high renin, that's meaningless. But if she has high aldosterone with low renin, then this is an autonomous production of aldosterone. But that's not the end of the workup yet. Because hyperaldosteronism can happen from hyperplasia or from adenoma. If it happens from hyperplasia, it is best managed medically. If it happens from an adenoma, it is best managed surgically. As in many other endocrine conditions, hyperplasia still to some extent responds to physiological stimuli, where adenomas typically do not. So once you have determined that there is high aldosterone with low renin, we repeat those determinations with the patient lying down and with the patient standing up, so that we have then elicited the postural response that we normally have with a higher aldosterone production when we're standing up than we're lying down. If the lady still makes that normal response, she probably has hyperplasia. If she doesn't make that normal response or does the opposite, she probably has an adenoma. Eventually then CT scan or potentially MRI of the adrenal gland and then removal of the adenoma. All right, the next one. A thin, hyperactive 38-year-old woman is frustrated by the inability of her physicians to help her. She has episodes of severe pounding headache with palpitations, profuse perspiration, and pallor. But by the time she gets to the doctor's office, she checks out normal in every respect. This presentation should make you think of the pheochromocytoma. It's not the only way pheochromocytoma presents, by the way. Pheochromocytoma could have a sustained type of hypertension there all the time. But it makes a better examination question to pick the variant of the pheochromocytoma where you have the paroxysmal hypertension. Because in that one, at the time of the catecholamine production being dumped into the blood, the lady thinks she's going to die. She has this tremendous headache, the palpitation, she's pale. If you were to measure the blood pressure at that time, it would be 300 over something. But in that paroxysmal form, by the time the patient gets to the doctor's office, it's like that proverbial noise that your car makes, and when you go to the mechanic, the car doesn't make the noise anymore. This is what happens to this lady. So the vignette may show you that frustration from a patient who's been from doctor to doctor saying, I think I'm going to die with these horrible attacks, and nobody can find anything. We would begin the work up here with a 24-hour urinary collection for metanephrine or VMA or both. VMA is easier to do as vanillin mandelic acid. Metanephrine is a little more difficult. Not every lab can do metanephrine, but it's a better, thing to determine. And then we follow with CT scans of the adrenal glands. Now, these tumors, incidentally, are typically pretty big. The pheochromocytoma is kind of a peculiar tumor. It makes catecholamines. It also breaks down catecholamine. And so you'll never see a patient with symptomatic pheochromocytoma that's only this big. Because when it's that small, it makes it and it breaks it. But when it gets to be huge, it makes so much that even breaking it, still enough gets into the circulation to give you trouble. So typically when we do that CT scan, we see a tumor that is 5 or 6 cms, a big tumor. And then eventually surgery. And incidentally, the hero at the time of the operation is the anesthesiologist, not the surgeon, because there's a very careful pharmacological preparation that is needed to block the catecholamines and enable the surgery to be done safely. All right, vignette number 3. A 17-year-old man is found to have a blood pressure of 190 over 150. This is checked repeatedly in both arms, and it is always found to be elevated. But when checked in the legs, it is found to be normal, and that's classical for coarctation of aorta. Coarctation of aorta is seen in a young person. It's a congenital anomaly. And if it gets to be of this age, 17 or more than that, we have that pretty characteristic thing that in the lower half of the body, there is no hypertension or sometimes no big palpable pulses. There is a difference between the upper half of the body that is hypertensive and the lower half that is not. If it is not already included in the vignette, the first thing you want here is a chest X-ray. Because when the coarctation of the aorta has been present for these many years, there is tremendous collateral circulation to around the coarcted segment. And that involves intercostal vessels, and they get to be huge, and they erode the undersurface of the ribs. And so they are scalloped, eaten away by the pounding of these collateral vessels. And then after that, we need to look at the aorta to see that area of coarctation, which is typically at the junction between the arch and the descending. Up until not too long ago, the only way to get that good quality picture of the aorta was an aortogram, an arteriogram, an angiogram. But nowadays we have non-invasive ways of doing the same. And of the 3 non-invasive things that can be done, the transesophageal echo, the MRI angio, or the spiral CT scan, the one that seems to be gaining favor is the spiral CT scan. It's easy to do. CT scan machines are available everywhere. It's easier to do a CT scan than to do an MRI. And it doesn't have the intrusive thing of putting that probe into the esophagus that you need to do the transesophageal echo. So in many instances, we can make the diagnosis here with a spiral CT scan and not need to do an arteriogram and then proceed with the repair. And then the last one, vignettes 4 and 5. 23-year-old woman has had severe hypertension for 2 years, and she does not respond well to the usual medical treatment for that condition. A bruit can be faintly heard over her upper abdomen. Vignette number 5, a 72-year-old man with multiple manifestations of arteriosclerotic occlusive disease, has hypertension of relatively recent onset, and refractory to the usual medical therapy. He has a faint bruit over the upper abdomen. Both of these are examples of renovascular hypertension. And the clue, what alerted you to it, is that faint bruit over the upper abdomen or the flank. And that faint bruit obviously is the blood going through that narrow spot at the origin of the renal artery. Renovascular hypertension, as you know, comes in two variants. We can see it in young women, in which case it is due to fibromuscular dysplasia. Or we can see it in the elderly man that has arteriosclerotic occlusive disease because of a plaque at the origin of the renal artery. The workup in both cases would require that we see that vessel and the plaque and do something about it. But the workup is far easier and more imperative to do in the young lady. The young lady has no other anomaly except this fibromuscular dysplasia and hypertension. She still has 50 or 60 or 70 years of life ahead of her, and it's imperative that we cure her hypertension. So we do the studies on the young lady. We may begin with non-invasive things like Doppler studies or duplex scanning. May need to move on to more invasive things like an arteriogram, and eventually end up typically dilating this area and putting a stent in it. The workup for the old man is a little more controversial, because if he has multiple manifestations of arteriosclerotic occlusive disease, it may very well be that he's going to die from something other than the hypertension. He may have abdominal aortic aneurysm, he may have cerebrovascular disease, he may have coronary disease. In other words, this is not only hypertension that is a problem for the patient. The hypertension may or may not be the biggest problem. So whether one does a workup and to what extent that workup is done is more debatable in the old patient. All right, we're going to move on now to the last of the items under the general heading of general surgery, and these are pediatric surgery cases. I have organized them by the age when they show up. Age, after all, is always the first item of information in every clinical vignette on an exam. It's always a so-and-so old so-and-so. All right? So the first group are conditions that we see at birth or during the first 24 hours. Vignette number one, within 8 hours after birth, it is noted that a baby has excessive salivation. Let me stop right there. Excessive salivation should already have given you the diagnosis. Ask any physician who's been in practice for a number of years. How many patients have walked into their office to say, "Doctor, I'm worried I make too much saliva"? That doesn't happen. When we see in a vignette excessive salivation, and it is a newborn, this immediately tells us there is esophageal atresia, probably with a tracheoesophageal fistula. The saliva has no place to go and it's coming out. It could also say when the baby was first fed, there was a choking spell. But here we have the excessive salivation. A small, soft nasogastric tube is inserted, and the baby is taken to X-ray to have a babygram done. Let me interrupt again. This is, not perhaps a very scientific word, but is used extensively in pediatric circles. A newborn baby is this big. An X-ray plate is this big. So you don't send a newborn baby to the X-ray department and say, "Please give me an X-ray of the arm or the leg." They give you an X-ray of the entire baby. They put the baby there, they shield the gonads, and they shoot a picture. And that's what the pediatricians call a babygram. Well, the babygram is done here, and the film shows that soft nasogastric tube that had been inserted to be coiled back upon itself in the upper chest, and that confirms the diagnosis of esophageal atresia. And the last line says there is air in the gastrointestinal tract, which in turn confirms that it is the most common of the 4 types of esophageal atresia. The one that has a blind pouch at the upper end, and has a fistula between the tracheobronchial tree and the lower esophagus at the lower end. And that's how the air got into the GI tract, via the fistula from the trachea. So you say, okay, we have the diagnosis. This is a esophageal atresia with tracheoesophageal fistula, the most common type, and the baby therefore needs an immediate operation. No, don't jump to conclusions. The TE fistula is one of a constellation of congenital anomalies that often coexist in the same patient at the same time. And before we rush to the operating room to take care of the esophagus and the tracheobronchial fistula, we need to rule out the others. The mnemonic used to remember these is VACTOR. Vertebral anomalies, anal anomalies, cardiac anomalies, tracheoesophageal fistula, and renal and radial anomalies. So on that babygram that was already done to see where the nasogastric tube went, we look for the radial anomalies and the vertebral anomalies. On physical exam, we look at the anus to see if there is an imperforate anus. And then we do an echocardiogram for the heart, and we do sonograms for the kidneys. And then we're ready to proceed. If there are no other anomalies that would prevent dealing with the tracheoesophageal fistula, then repair is done on the first day of life. If, on the other hand, other things have to be attended to and it is impossible to immediately address it, then we put a gastrostomy tube. Because otherwise, through that distal fistula from the tracheobronchial tree to the distal end of the esophagus, you're going to have acid from the stomach getting into the tracheobronchial tree. Well, we could be given any of the components of a VACTOR constellation as the question on the exam, opinion number 2. A newborn baby is found on physical exam to have an imperforate anus. Well, you say, okay, that's it. There's a diagnosis. Off to the operating room to fix the problem. Well, the patient could have any of the other things too. So now this baby needs a soft, small nasogastric tube inserted, be taken to the X-ray for a babygram. We need to see that tube's gone into the stomach or not. We need to look for the renal and the anomalies with the sonogram, the cardiac anomalies of an echo, the radial and vertebral anomalies in the X-ray. And if all we are left with is the anal anomaly, then we want to find out 2 things. By physical exam, is there a fistula nearby? Sometimes a baby that has an imperforate anus has a fistula nearby to the vagina or to the perineum, and in that case the fistula serves to vent the GI tract, and there is less urgency to do something about the problem immediately. If there is no fistula nearby, then we need to determine next how high is the blind pouch of the anal canal. We typically do that by taking an X-ray with the baby upside down, a little marker taped to the anus, and we see the distance between the gas that is in the GI tract and the marker. If it is very close to the anus, we may be able to do a simple repair immediately. But if it is a more complicated situation, we may opt for a diverting colostomy, so that at a later date, when the baby is bigger and better developed, we can do then a more definitive repair, preferably before the age for toilet training. Vignette number 3. The newborn baby is found to be tachypnic, cyanotic, and grunting. The abdomen is scaphoid, and there are bowel sounds heard over the left chest. An X-ray confirms that there is bowel in the left thorax. Shortly thereafter, the baby develops significant hypoxia and acidosis. This is a congenital diaphragmatic hernia, always on the left, not on the right. And the congenital diaphragmatic hernia poses a severe problem, not so much because of the obvious mechanical fact that there is a hole in the diaphragm, but because that lung is a hypoplastic lung. And the baby still has, to some extent, fetal-type circulation through that lung. So resist the temptation then to pick the answer on the exam that says rush to the operating room and sew up the hole in the diaphragm. That's not the critical point. These babies need to be given 2, maybe 3 days in which to further develop their pulmonary function, get more maturation of the lung before the repair is done. During that time, they need very extensive respiratory support. They need to be put on a respirator, but with very careful not to blow up the good lung. And so we have to provide significant support to allow for maturation. Let me add a little twist to this particular vignette. It is presented here as a newborn baby. But now, to make this vignette realistic, it really would have to say a newborn baby born to a mother who had no prenatal care. Because nowadays we can diagnose this diaphragmatic hernia in utero with sonograms. So women that have proper prenatal care often would not be surprised at the time of birth to find that the baby has this congenital anomaly, because it would have been recognized in utero. When it is recognized in utero, then the proper steps can be taken to be ready to provide the respiratory support the baby may need. And in fact, if it is a significant defect that allows a prediction of very bad respiratory problem, the lady might even be transported to a place so that when the delivery occurs, it's an institution that has ECMO, extracorporeal membrane oxygenation, a very fancy way to provide respiratory support that the baby would need. All right, the next 2 vignettes have to do, in fact the next 3, with babies that are born with some kind of a defect in the abdominal wall. But let's read the description carefully, because these are different kinds of defects. Vignette number 4. At the time of birth, it is noted that a child has a large abdominal wall defect to the right of the umbilicus. There is a normal cord, and I assume this means the normal cord reaches all the way to the baby. But protruding from the defect is a matted mass of angry-looking edematous bowel loops. This is a description of a gastroschisis. And the gastroschisis, there is a defect in the abdominal wall. There is no membrane to protect the bowel, so the bowel has been in the amniotic fluid and is matted and angry-looking and inflamed. And there is a normal cord that reaches all the way to the baby. The defect is typically to the right of that cord. Very similar but different. Vignette number 5. A newborn baby is noted to have a shiny, thin, membranous sac at the base of the umbilical cord. The cord goes to the sac, not to the baby. And inside the sac, one can see part of the liver and loops of normal bowel. This one is an omphalocele. So we have 2 conditions characterized by a defect in the abdominal wall at the level of the umbilicus. One is a gastroschisis, one is an omphalocele. In both of them, you realize intuitively that we need to put that bowel back inside the abdomen where it belongs and close the abdominal wall. But unless it's a very small defect, we typically cannot do that on the day of birth. So often what happens is these kids are taken to the operating room, and we create a little container to house and protect the bowel. And from that container, in subsequent days, we gradually squeeze the bowel back into the abdominal cavity. This little container is typically made out of silastic or some other plastic material. It is sewn to the belly wall and made into a little cylinder. And there is a classical word you're going to find on the question, because everybody who refers to one of these contraptions always calls it a silo, like the silos and the farms where they house the grain. Okay. So look for the answer on these vignettes that says construction of a silastic silo to house and protect the bowel, and then every day a little bowel is squeezed in, a row of sutures or a clamp is placed on the silo, and after about a week, all the bowel is back into the baby, and then we can close the defect. Let me add that in the baby with a gastroschisis, It's also necessary to provide venous access for long-term parenteral nutrition. Because that baby that is born with that angry-looking, inflamed, edematous bowel that was in the amniotic fluid, that bowel isn't going to work for a month. And so nutritional, parenteral nutrition is going to be needed, and the vascular access is therefore required. Now the third one, I said at the beginning, there are three potential defects in the belly wall, is different. Vignette number 6. A newborn is noted to have a moist medallion of mucosa occupying the lower abdominal wall, above the pubis and below the umbilicus. It is clear that urine is constantly bathing this congenital anomaly. That is, in fact, extrophy of the urinary bladder. The pubic symphysis didn't close, the bladder didn't close. And you have the back wall of the bladder outside. This is a difficult anomaly to repair. It takes highly specialized care to do it. Only very specialized centers can do it, and there is urgency. The best outcome will be obtained with a prompt repair in the first day or two of life. And so I think the answer you're looking for on this one is the one that, rather than let's stabilize a baby, make him grow a little bit, and then refer him, is the answer that calls for immediate transportation to a highly specialized center. Now we come on to a number of instances of babies that have two things happening to them. They're vomiting green fluid, and they have a peculiar X-ray picture that we're about to depict here for you. Vignette number 7. Half an hour after the first feed, a baby vomits greenish fluid. Let me stop right there. Babies vomit all the time. It's no big deal for a baby to vomit. But the inconsequential vomiting that babies have all the time is white fluid, not green fluid. Bilious vomiting, greenish vomiting in the newborn period. That's pretty ominous significance. There is something serious going on with the baby. The mother has polyhydramnios and the baby has Down syndrome. X-ray shows a double bubble sign. A large air fluid level in the stomach and a smaller one in the first portion of the duodenum, and there is no gas in the rest of the bowel. I'm going to make you a little drawing here of what this double bubble sign looks like. So we would have the entire baby in the X-ray picture, like we've already indicated. So here is the little kid. And in the one that I'm describing right now, we see in that baby two large air fluid levels. A bigger one on the left and a smaller one on the right. This is the famous double bubble. This one is the stomach, and this one is the duodenum. This particular vignette says there is no gas in the rest of the bowel. Another forthcoming vignette is going to say that there be a little bit of gas in normal-looking loops of bowel beyond. We're going to analyze the significance of each of these. So we would have the picture then of the baby in the X-ray plate, and the baby would look like this, and then in the X-ray picture we would see a large air fluid level here and a smaller one next to it. The one to the left represents the stomach with an air fluid level. The one to the right is the first portion of the duodenum with an air fluid level. Now we're going to see another vignette in a minute where, in addition to these two, there are a few loops of bowel that have a normal gas pattern beyond this double bubble. And there is a significance to that we'll talk about in a minute. But if we start then with this basic picture here. This child then has the green vomiting and the double bubble. Could have three conditions. This child could have duodenal atresia, annular pancreas, or malrotation. And the child that has a double bubble, as well as the few loops of bowel beyond that have gas in them, is even more likely to have a malrotation out of those three. So let me repeat again, any child with a green vomiting on the first day of life that has a double bubble sign could have annular pancreas, could have duodenal atresia, or could have malrotation. If that baby also happens to have those few little loops of bowel beyond the double bubble that have gas, is more likely to have malrotation. Now the importance of all of these. All three of these conditions are going to need surgical repair. If there is duodenal atresia, we have to create a connection between the first and the third or fourth portions of the duodenum. If there is annular pancreas, we do the same. We bypass the area that is occluded. But of these three conditions, the one that potentially is the most devastating, the most lethal of the three is malrotation. Because in malrotation, the main threat to the patient's life is not simply the duodenal obstruction that is caused by the large bands that are there. But in malrotation, the entire small bowel is dangling from the mesenteric vessels without an attachment to keep it in place. And that bowel can very easily twist one way or the other and then die. And so when a pediatric surgeon is told that a newborn baby has been having green vomiting and exhibits a double bubble sign in the X-ray picture, that pediatric surgeon wants to know as soon as possible, is this due to malrotation? Because if so, there's a greater urgency in intervening surgically. Well, there are two ways we can demonstrate if there is malrotation or not. We can do it with a barium enema. We can do it by putting contrast material from below and finding out if the colon is in the normal position or not. Or we could do it by putting contrast material from above, a barium swallow, upper GI, and finding out if the duodenum has a normal curve and continuous or all the small bowel is on one side. Of these two tests, the one from below is safer, but not always as diagnostic. The one from above is a little riskier because the baby is vomiting and you're putting barium that the baby then could vomit and aspirate. But it has a better diagnostic accuracy. I've heard many individuals who are experienced pediatric surgeons say, I prefer the barium from above, it gives a better diagnosis, but given the fact that it is riskier, it might not be the best answer on the USMLE. The USMLE doesn't want you to be doing risky things. Now, if both choices are offered, I would pick the barium enema. If only one of the two is offered, then you have less of the dilemma. But again, we're going back now to the summary. Newborn baby, green vomiting, double bubble radiological sign. The next thing we want to do is to determine if this is malrotation, which we can do with barium from below or from above. And if it is malrotation, it's extremely urgent that we operate immediately on the baby, not only to correct the obstruction, but also to make sure that the bowel doesn't have an opportunity to twist and die. If it's one of the other two, if it is not malrotation, we still are going to have to operate, but there's a little less urgency to it. Well, vignette number 8 was the one that I was anticipating. Half an hour after the first feed, a baby vomits greenish fluid. X-ray shows a double bubble sign, a larger fluid level in the stomach, a smaller one in the first portion of the duodenum. There is air in the distal bowel beyond the duodenum in loops that are not distended. This baby has a very high probability of being malrotation. He needs those X-ray studies immediately. There is another way that we could see the newborn baby with the green vomiting. Vignette number 9. A newborn baby has repeated green vomiting during the first day of life and does not pass any meconium. Except for abdominal distension, the baby is otherwise normal. X-rays show multiple air fluid levels and distended loops of bowel. So this is not double bubble. This is many air fluid levels. When we have many air fluid levels, this is probably intestinal atresia. And intestinal atresia will also need to be operated on because the bowel ends have to be reconnected. But intestinal atresia is sort of unique among these congenital pediatric surgical situations, because intestinal atresia is not, in fact, a problem with the genes or the chromosomes. Intestinal atresia happens from a vascular accident in utero. And so in the baby with intestinal atresia, we don't need to be looking for other congenital anomalies that could coexist. The baby simply had an accident, a vascular accident in utero. All right, now we move on to pediatric conditions that we see a few days out, but still within the first month or two of life. Opinion number 10, a very premature baby develops feeding intolerance, abdominal distension, and a rapidly dropping platelet count. The baby is 4 days old and was treated with indomethacin for a patent ductus. When you see in an exam question the combination of a premature baby and then abdominal problems when the baby is fed, this will invariably be necrotizing enterocolitis. It's almost like there is a shortcut here. We read premature trouble when the baby was fed equals necrotizing enterocolitis. We have to stop all the feedings, use broad-spectrum antibiotics, intravenous fluids and nutrition. And surgical intervention is called for only if we have signs that the bowel has died. Abdominal wall erythema, air in the biliary tree, or pneumoperitoneum are the ones usually quoted. Opinion number 11. A 3-day-old full-term baby is brought in because of feeding intolerance and bilious vomiting. X-rays show multiple dilated loops of small bowel and a ground glass appearance in the lower abdomen. The mother has cystic fibrosis. Here is another combination that gives us a shortcut, a quick way to the diagnosis. Any combination of cystic fibrosis plus something wrong with the GI tract, feeding intolerance, and bilious vomiting, that equals meconium ileus. Actually, this baby has cystic fibrosis. It hasn't been diagnosed yet because it's only 3 days old. But the fact that the mother has it gives us a connection, gives us a diagnostic clue. There are two conditions in the pediatric surgical group where a diagnostic test also serves as the beginning of therapy, and this is one of the two. What this baby needs, the answer on the exam, is a gastrographic enema. The gastrographic enema will make the diagnosis, will show the unused microcolon, feces that never got into it. And as it refluxes up the terminal ileum, it'll show the pellets of meconium that are inspissated there. But as it does that, gastrographic happens to be a very hypertonic solution. It also draws fluid into the lumen, and it will dissolve or help dissolve the meconium pellets. So the gastrographic enema is both diagnostic and therapeutic for the baby with meconium ileus, and therefore the correct answer on the exam. Now, vignette number 12 may at first sound a bit tricky. Let's read it. A 3-week-old baby has had trouble feeding, 3-week-old, and is not quite growing well. He now has bilious vomiting and is brought in for evaluation. X-rays show a classical double bubble, along with normal-looking gas pattern and the rest of the bowel. We already had indicated earlier that green vomiting, double bubble, and gas beyond is highly suggestive of malrotation. We're now adding the fact that malrotation often shows up on day 1, but it may not show up until day 3 or 5, or as in this case, 2 or 3 weeks. So the possibility of malrotation showing up isn't limited to day 1. It could be presented to you on the exam as a problem on day 1, but it could be presented to you on the exam as a problem on day 5 or on 2 weeks or 3 weeks out. And you know what to do. We're going to need either the barium enema or the barium from above to confirm the diagnosis, and then the surgical intervention to prevent that bowel from twisting and dying. Okay, the next vignette is a 3-week-old a baby, and we're told that his firstborn, full-term baby boy, began to vomit 3 days ago. The vomiting is projectile, and we already have the answer here. The diagnosis is already obvious. 3 weeks old with projectile vomiting. Now, if you and I had projectile vomiting at our age, it'd be bad news. It would mean we have a brain tumor. But projectile vomiting at age 3 weeks is invariably hypertrophic pyloric stenosis. And as we keep reading, we'll see the rest of the picture developing. So this vomiting is projectile, has no bile in it. That makes sense. If the pylorus is occluded, there is no bile in the vomiting. Follows each feeding, and the baby is hungry and eager to eat again after he vomits. He looks somewhat dehydrated and has visible gastric peristaltic waves and a palpable olive-sized mass in the right upper quadrant. That palpable mass is the hypertrophic pylorus. But that palpable mass is also the second clue. If you didn't already have a diagnosis when you read that a 3-week-old was having projectile vomiting. Because this pylorus that can be felt, it could have been described as a little round mass, an ovoid mass, a little mass that is 2 cm by 1 cm. But the typical designation, but for some reason every person who writes about pediatric surgery always says, is an olive-sized mass. So the term olive-sized mass immediately tells you this is hypertrophic pyloric stenosis. Okay, what are we going to do for management? Actually, no more diagnostic tests are needed. You already have a diagnosis. If you needed more diagnostic tests, please go for a sonogram rather than putting barium in a stomach that already is occluded with the pylorus, because that baby is going to vomit that barium and aspirate. But now we're ready to treat the patient. However, don't jump to the surgical treatment. These babies, when we see them, invariably are dehydrated, and they have hypochloremic, hypokalemic, metabolic alkalosis. That has to be corrected first. So look for the answer on the question where you rehydrate the patient, correct the hypokalemic, hypochloremic, metabolic alkalosis, and then we operate. We do a little operation called a Ramstead pyloromyotomy. It's a little cut that we make that opens the fibers of the pylorus and resolves the problem. All right, now we're talking about a little older baby in the next vignette, vignette 14. An 8-week-old baby is brought in because of persistent, progressively increasing jaundice. The bilirubin is significantly elevated, and about 2/3 of it is conjugated direct bilirubin. Serology is negative for hepatitis, and sweat test is normal. If the vignette had been jaundice at age 2 or 3 weeks, there are other reasons for that. But if a baby is 8 weeks old and has persistent progressive jaundice, we have to think of biliary atresia. Now, the diagnosis of biliary atresia is a complicated, multifactorial one. We do a lot of tests for that. But probably the most reliable test, what I would expect to be the answer you will find in the exam, is an IDA scan. Remember that radionuclide scan we talked about apropos of the acute cholecystitis? An IDA scan done 1 week after phenobarbital therapy. Let me explain this. Phenobarbital, although you think of it as a sedative, a hypnotic, something you take to go to sleep, is also a very powerful choleretic. So when we put that baby on phenobarbital, we are stimulating that liver to make as much bile as possible. And after a week of that stimulation, we do the IDA scan. If that IDA scan shows that the contrast, the radioactive material never leaves the liver, doesn't go down a set of ducts to the duodenum, then we've shown that the baby has atresia. And on the other hand, if After the 1 week of phenobarbital, we find with the IDA scan that there is bile in the liver, bile in the ducts, and bile in the duodenum. The baby has another reason for the jaundice. Babies that have biliary atresia face a pretty uncertain future. We operate on them when we make the diagnosis. At the time of surgery, we find that about a third of them cannot be repaired at all, and we have to do a liver transplant. We find the others that we can repair them, but only about a half of those that we repair remain well after the repair, so that another third eventually ends up also requiring liver transplant. Vignette number 15 is sort of a snapshot on the potential spectrum of a disease that is with many different presentations. A 2-month-old baby boy is brought in because of chronic constipation. The kid has abdominal distension, and plain x-rays show gas in dilated loops of bowel throughout the abdomen. Rectal exam is followed by explosive expulsion of stool and flatus with remarkable improvement of the distension. The disease that I was referring to, that may present in many different ways, is aganglionic megacolon, Hirschsprung's disease. The key centerpiece, though, will be constipation. And you have to guess that in the USMLE, if they give you a question with a child that has constipation, it's probably not just plain constipation. It's probably something more important, something deserving to have a question in the USMLE. Well, depending on the length of the segment of bowel that is aganglionic, the presentations really vary all over the map. I have known of babies that were completely obstructed on the day of birth, and they had to go to the operating room on the day of birth with complete obstruction and green vomiting and multiple fluid levels, and it was due to the fact that the entire colon was aganglionic and nothing could get beyond the ileocecal bowel. There are, on the other hand, examples of people that are 10 or 15 or 20 years old before aganglionic megacolon is diagnosed, because they have only a short segment which the rest of the bowel is able to propel the feces through. But again, the centerpiece of a presentation for aganglionic megacolon will be a baby or a child with chronic constipation. Let me add a little bit to differential diagnosis here. If you're given a picture on the exam, or a question on the exam, of a baby beyond the time when babies undergo toilet training, and you're told this 6-year-old or this 5-year-old is chronically constipated, is distended, he doesn't go to the bathroom but once a week, but you're told in that vignette that rectal exam shows a rectal vault full of feces, and that the history includes frequent episodes of fecal soiling, then you probably have a mental problem. Then it's not a ganglionic megacolon. The feces are getting to the anus. The child has some psychological problem that he doesn't want to go to the bathroom. But on the other hand, if there's an empty rectal vault, then things are not getting there. A very classical presentation for the ganglionic megacolon in an older person would be chronic constipation, a barrio minima is done. And the barrio minima shows a segment of normal-looking colon, and above that, the rest of the colon is massively distended. Actually, that X-ray picture shows what appears to be the normal colon is in fact the aganglionic colon, the one that doesn't have propulsion. And what appears to be distorted, the big colon above that, is the ganglionic one, the properly innervated one, that has become enormous from trying to propel feces through the area that doesn't have innervation. In either case, if you have a vignette that you have reason to suspect because constipation is a central feature, but it may be a case of aganglionic megacolon, the way you make the diagnosis is a full thickness biopsy of the rectal mucosa. All right, so look for that answer. Full thickness biopsy of the rectal mucosa. Now we move on to later in infancy. And vignette 16 gives us a 9-month-old baby. Actually a 9-month-old, chubby, healthy-looking little boy who has episodes of colicky abdominal pain that make him double up and squat. The pain lasts for about 1 minute, and the kid looks perfectly happy and normal until he gets another colic. Physical exam shows a vague mass on the right side of the abdomen, an empty right lower quadrant, and current jelly stools. And current jelly stools is the tip-off. This baby has intussusception. Intussusception happens in this age group. The kids have the terminal ileum telescoped up into the ascending column. This happens in an intermittent way. And so when it's telescoped up there, the kid is having a colicky pain and is very unhappy. And when it, reduces itself, the kid is happy.